Good day, everyone, welcome to the symposium sponsored by the American Society of Gene and Cell Therapy. And our symposium is entitled Cell Therapies in the Middle East, Where Do We Stand? This symposium will be given over 2 days, and it'll cover new advances in cancer therapy. And on day one, we're going to concentrate on advances in CAR T therapy for cancer. Before we get started, I'd like to thank the organizers and particularly Dr. Ali Bazabakte from the American University in Lebanon, who was really instrumental in helping identify the speakers for our symposium. I'd also like to thank Dr. Jay Rao, who is the chair of the Global Outreach Committee for the Society, and he'll be moderating tomorrow's talks. I'm also especially grateful to Dr. Mohammed Moti, who will be joining and leading our panel discussion. And today we're going to have 3 speakers. They will give their talks, and I encourage everyone to put any questions you have in the chat, and we'll moderate them and bring them into the panel discussion, which will be at the end of everyone's talk. Also, going to give a shout out and thanks to the folks at the Society, particularly Sam Kay and the other folks who have been helping put this together and helping the logistics here. Before the speakers start, I'd like to share a couple of things that at least sort of which led to our discussion today. And to share my slides. And let's see. And one, who am I? I'm Ken Cornetta, as I mentioned. I'm a professor of clinical and medical molecular genetics at Indiana University and member of the American Society of Cell and Gene Therapy Global Outreach Committee. Just to give you just a little bit of background about the Society, we have over 5,000 members now, and our mission is to advance knowledge, awareness, and education leading to the discovery and clinical applications of genetic and cellular therapies. And again, our focus is to help alleviate human diseases. And in 2020 is when our current committee that has organized this symposium was brought into being, and it was one of the strategic priorities from the Society. And we're trying to look beyond folks from the US and seeing how we can best help them in developing and providing access to novel therapies, particularly genetic and cell therapies. And this is just sort of says what our goals would be. And really to give folks an understanding, which I think many in the audience are well aware of, the application of clinical trials in cell and gene therapy is really focused in high-income countries, such as the US and in Europe. And this just is from clinicaltrials.gov, showing that where most of these trials are. And so, as you can also see on the map, there are many areas of the world where there's very little access to ongoing clinical trials. And a big challenge for everyone is as these things move from clinical trials to actually approved clinical products, the expense of many of these therapies are astronomical and extremely challenging. And they're a challenge no matter where you live in the world of how are we going to be able to afford many of these therapies. And so what is the current status of bringing things into clinical trials? And if we think about it, if we have a concept for a novel cell or gene therapy, we need to develop that target identification, move things along for development in terms of validating and doing preclinical efficacy and safety studies, manufacturing a cell product or a gene therapy product, and then having that clinical trial and eventually having it licensed. That's a long pathway, but also to get that, if we're talking in academics, and many folks in the area have been doing this, it really requires collaborations between basic scientists, clinicians, and then also being able to do things locally in terms of being able to process cell and gene therapy products, to manufacture them, to provide them to our patients, either under clinical trials or on, or if they are commercial products, providing them. And that requires hospital support as well. So it's a coordination. And what we're seeing that there's very few places that can do all of this. And as a society, we'd like to foster education, really look at where are folks doing research, because while it's complicated to do everything, there are folks throughout the world who are doing various parts of this. And how do we try to, again, make sure the community can learn from each other in bringing these things forward? So as a society, just wanted to make folks aware of, there are monthly professional development cafes and insight series that folks can participate in. There are a number of free resources around patient education. And also, if you're looking to see where clinical trials are being done, the Society's website and asgc.org has a number of these resources available to anyone. Also, we've tried to get more involvement from folks outside the US. And if you are interested in becoming a member, if you're from an upper middle income country, there's a 50% dues reduction. If you're lower middle income, it's 75. And if you're a lower income country, it's a 90% reduction in dues, trying to foster access to folks who may be interested in this area. This symposium today is actually part of a series of symposium that we've held. And it's been very interesting to hear some of the advances and thinking in different parts of the world. And so as a society, we also hope to learn. So we'll be paying special attention to the kind of questions that we have and comments we may hear from our speakers and participants. And just make folks aware, there'll be other things coming along the way. We are looking at developing training, the trainers, and we're doing this in collaboration with a university in Tanzania. And what we're trying to do is make available to faculty in lower middle income country who are at the medical school or a graduate school level, allowing them to learn about gene therapy so they may develop a course or a class within their institution that provides new learners with information about gene therapy, particularly a focus on gene therapy clinical trials. Again, we hope to raise awareness of these disparities and make that known to particularly commercial folks who are developing these trials. And then we will look to provide resources and training of researchers in various countries outside the high-income countries to be able to learn more and actually facilitate clinical development in their country. So I will leave this up for just a second if you do need more information about the society and things, but mostly we'll be getting ready to go ahead and hear from our speakers today. And I think the first speaker that we're going to hear from today is Dr. Rafat Abernor, who is a specialist in cancer therapy at the IU Simon Cancer Center here in Indianapolis, Indiana. He earned his medical degree at the University of Damascus, and he's currently the Henry and Edith Gladstein Professor of Cancer Research at Indiana University. And he'll be talking to us today about CAR T cells for multiple myeloma.
Good evening, and thank you, Dr. Cornetta and Dr. Moti, for inviting me to talk to you today about CAR T cell therapy for multiple myeloma. As you know, multiple myeloma is a rare blood cancer, and to date we don't have curative options. However, survival has improved significantly thanks to the availability of many new and expensive drugs today. I think immunotherapy is changing the course of this disease, and we probably start talking about cure soon. So just to remind you that patients with multiple myeloma tend to have a long course, present usually with monohemoglobinopathy or smoldering multiple myeloma. At some point they become symptomatic and they require first-line therapy. And then they can go into remission, and eventually they relapse, and they'll get another response, and then they relapse. And luckily, we have multiple treatment that can help the patient survive each relapse. However, the sort of the hallmark of each relapse is that the depth of response is less pronounced, and the duration of response also shorter, and eventually the patient become refractory. And the importance of the depth of response really comes from observation that patients with partial response or very good partial response tend to have a shorter duration of response, and they progress quickly, which also translate to shorter overall survival. Stringent complete remission, which is the disappearance of clonal plasma cells in the bone marrow, immunofixation is negative, and the free light chain levels and ratio are normal, still the patients tend to have a shorter duration of remission. However, our ability to look at minimal residual disease, either by flow cytometry or by next generation sequencing, has shown that achieving that level of response does translate to a prolonged remission and also overall survival. So really, Sarah, it seems to us at this point that a regimen or a treatment that lead to a high level of MRD negativity is something that we all aspire to achieve for our patients, to try to extend their remission, their survival, and perhaps curing them. So this is sort of the evolution of myeloma therapy. As you know, most patients obviously require an induction, consolidation, post-consolidation treatment, such as maintenance or further consolidation, or a rescue, obviously, for relapse patients. And when we started, we had very, limited options. Maybe the Velcade dexamethasone, bortezomib dexamethasone, lenalidomide dexamethasone, and then combination of these, and then high-dose melphalan, and then maintenance. We had nothing for a while, and then we start using thalidomide or lenalidomide and other drugs and combination of those as part of post-transplant care. And we had one or two options for relapse patients, and now you can see that the future is for drug regimen. Whether we need a stem cell transplant or not is really an area of active debate, especially after the determination trial presented as a plenary session at the American Society of Clinical Oncology meeting about a week ago. But I think today we're going to talk about CAR T cells and immunotherapy. What are the targets for immunotherapy? I think the first target that people have looked at was CD38, and clearly the two antibodies we have today, daratumumab and isatuximab, producing significant benefit in both the newly diagnosed and relapsed patients. SLAM-F7 seems to be useful as a target in the setting of relapsed patients in combination with pomalidomide. But the most exciting target is BCMA, whether you use an antibody that is conjugated, such Blenrep or belantamab, and the bispecific T-cell engagers, and obviously CAR T-cells, which we will talk about. So why BCMA? Why B-cell maturation antigen? It's a member of the TNF receptors and regulate B-cell proliferations, survival, and maturation to plasma cells. It is expressed and activated with myeloma cell growth and survival, and it's exclusively expressed on the surface of plasmablast and differentiated plasma cells. So it's an excellent target because obviously inhibition, the BCMA, does lead to the myeloma cells apoptosis, but also the lack of expression on other tissues makes it a very attractive and less toxic to the patients. Obviously, immunodeficiency and low immunoglobulins, one need to remember that when you're treating patients with BCMA-targeted therapy, and the need for prophylactic antibodies or intravenous immunoglobulin need to be kept in the back of our mind. So again, we all familiar with CAR T-cell therapy. You need to get the patient's T cells by leukapheresis of mononuclear cells. Then you enrich them for T cells, and after that you expand them and you add transfuse the cells with a lentivirus CAR construct, and then expand these cells and do a final isolations, and now you have a CAR T cell product that is BCMA specific. You give the patient lymphodepletions and then infuse the T cells. Today in America, we have 2 CAR T cells available commercially. One is the BB2121 or the IDA cell, and this product is tested through the KARMA program, and the first treatment was basically to look at those escalations of these cells. So they looked at 150 million cells, 300 million cells, 450 million cells to look at the overall response rate. And these were heavily pretreated patients. The median number of prior therapy was 6. And you can see that with dose escalation, the overall response rate increased from 50 to 82%, giving an overall response rate of 73%. But really the most important thing is that the depth of response, getting a complete remission with MRD negative results, was about 25% in the 150 million cells, 29% in the 300 million cells, and 39% in the large dose of CAR T cells. In the whole group, the number of complete response was MRD negative was 33%. So clearly a very active regimen in heavily pretreated patients that expect to see in the best salvage treatment about 30% overall response rate. The side effect, obviously 2 major ones that we all familiar with and now know how to manage are the cytokine release syndrome was seen in 84% and neurotoxicity in 18% of the patients. With further follow-up of these patients, the median progression-free survival initially reported at 8.8 months. And when one look at the response based on the target dose, obviously the progression-free survival was looking superior with larger dose of 450 million cells, and the patient who would have the deepest response, obviously eradicating myeloma, led to a better progression-free survival. So the dose, I think, matter in terms of the progression-free survival, and achieving a complete response, MRD negative, does translate to a better progression-free survival. Larry Anderson from Dallas, Texas, presented the updated data on overall survival, and at 12 months, the overall survival was 78%, at 18 months was 65%, and at 24 months, the overall survival was 51%. So what do we know about IDA cell results? The safety is there, it's manageable. Both the cytokine release syndrome and the neurotoxicity is very effective. It translates to better progression-free survival, and it is probably better than any other salvage therapy. There is a phase 3 study that complete did accrual over a year ago. We all participated in that study. And basically what we're waiting to see is ide-cel better than any salvage therapy for that population of patients. And I think the quality of life improvement is significant because I think the patient is done after the CAR T cells. They're not getting any further treatment. And, we have a lot of patients who enjoy really a reasonable quality of life, running miles a month after receiving the CAR T cells. So it's, very effective treatment, and the phase 3 studies are completed, and we'll try to prove that. The other program is the CARTITUDE program, which is another CAR T cells that has been reported on again many times, and Thomas Martin from University of California, San Francisco presented the initial phase 1 studies, and this cytocell is also providing a binding domain that is sort of designed to confer a better avidity to the BCMA. And they have now a median follow-up of 12.4 months and showed a manageable safety profile and an overall response rate of 97% with a stringent complete remission of 67%. And the overall 12 months progression-free survival was 77% and overall survival of 89%. And the median progression-free survival was not reached in the initial presentations. And so these are impressive results. And if you look at the breakdown of the results, the overall response rate was 97.9%, and a large number of patients achieved a stringent complete remission. And the best response at 1 year of follow-up was a stringent complete remission of 67%, but really more importantly is at 2 years of follow-up, it's 83%. May suggest there is an expansion of these CAR T cells in the patients. Just to remind you that the median prior line of therapy in this group of patients was 6, and there was no new safety signals noted. The progression-free survival in the patient who are achieving a stringent complete remission obviously superior to all the patients who had a optimal response compared to the stringent complete remission. And the overall survival at 2 years was 74%, so the median has not been reached. And with further evaluation of patients achieving a MRD negativity at 10 to the minus 5 and sustained at 6 months and 12 months, the patients who achieved a sustained response more than 12 months enjoyed a significant progression-free survival. And you can see almost that the curve is flat for both the 6 month and the 12 months. Most patient has not progressed yet, and overall survival continue to improve. So I think updated clinical and correlative results from both studies is ongoing, and this is work presented by Dr. Napur Raj from Dana-Farber, looking at the subset of cells that have expanded in these patients. And what she's looking basically at the memory T cells. Are we inducing these cells, and are they expanding in the patients? And her data suggests that yes, there is an expansion of memory CAR T cells in these patients. And I think if you look at the patients in terms of response, there is continuing to be a significant overall response in that group of patients, and increased number of complete remissions in those achieving MRD negativity. And if you look at the duration of response, it's also obviously continuing to show advantage of larger number of cells. But I think the most important thing is here, if you look at the effector signatures, when it's positive, you can see that the probability of duration of response increase when these T cells are expanded. And so the patient who have high level of CD27, CD28, the memory profile had a better duration of response compared to the one that had low expression. So clearly, there are data to suggest that some patients are enjoying an expansion of memory T cells, and that's translating to improvement in duration of response. So how about, sometimes there's a problem collecting T cells from the patients. Can we use universal allogenic T cells? And this is a program called Allo 715, presented by several of my colleagues. And so this first in man sort of allo CAR T cells in relapsed refractory patients, basically what happened is that they did gene editing to disturb the T cell receptor alpha construct to reduce the risk of a graft versus host disease. And they edit CD52 genes to permit the use of allo cells and to selectively deplete host T cells while protecting donor cells. And so what were the results of that? Basically, what they showed is that they were able to enroll patients in this trial, and they were able to get to a dose level of 320 million cells. And really, basically, the presentation was to focus on dose level 3, and they had a median follow-up of 4 months. So it's early results, but what it looks like is that the overall response rate is approaching 71%. 46% achieve a very good partial response, and 25% of the patient achieved complete remission, stringent complete remission. The duration of response is about 8.3 months. However, the median follow-up is still short, so we need to see this data updated, and hopefully they'll be updated at this coming ASH. So do we need to just attack BCMA? Are there other targets now? A lot of patients have been exposed to BCMA therapy. Can we look at something else? And this is a trial presented by the group from Memorial Sloan Kettering, looking at targeting GPRC5D. And this was abstract 827 from last ASH. And basically, this is a very interesting target because it's mostly present on plasma cells. There are some expression on skin cells that need to be addressed. So basically, these are early results of 17 patients, and they are heavily pretreated patients. Some of them had prior BCMA therapy and prior CAR T cell therapy at 59 and 47% of the patient. So what were the results? They got a response in a significant number of patients, 69% of the patient, very good partial response in 44%. So it looks like patients, whether they had a prior BCMA therapy or prior CAR T cell therapy, still enjoyed a significant partial response and a complete response of about 38%. And some of the responses were MRD negative. So this is a very encouraging results that, hopefully we'll see more patient treated, and we'll see what the efficacy in larger number of patients. The other target that people are looking at, CS1, and this is work presented by Dr. Patel and the Mellini-1 study. And basically, again, this is a anti-CS1 CAR. This is the construct of it. And if we look at the results, this was, a dose escalation like any other studies, and with the objective response is safety and maximum tolerated dose. So in this dose expansion, they had a large number of patients that had, the number of patients is small, but they are heavily pretreated patients. So, and obviously we're waiting to see the results on most of the patients. There were a couple responses, but this is early. But it's worth presenting just to say that we are probably going to go beyond BCMA. So what are we going to do today? I mean, CAR T cells arrive, what do we do? Do we wait until fourth line of therapy, like based on the label that is indicated? What if you have a young patient, was a young kid, and you already did use all of your active treatment early on? Should we start looking at really using CAR T cells early? There are several programs that are being investigated for looking at CAR T cells as an initial treatment for high-risk patients. I think if we overcome that hurdle and we show that it's effective and safe as a first-line therapy or second-line therapy, then I think we're going to make a huge change. So what is, my conclusion? I think the problem with BCMA CAR T cells therapy today is really available for a few patients. Production is very slow, and patient can wait on the list for CAR T cells up to 6 months. So it's not available widely. I mean, I think if a center can start producing their own CAR T cells, maybe that's an answer, because waiting for manufacturing is a problem. I think the bottleneck is also the vectors. Having enough vectors around is important. I think, there are newer CAR T cells models on the horizon, so hopefully that will answer some of the issue of efficacy and safety. We are seeing long-term MRD negativity now, but there's no cures yet. And I think the future of immunotherapy is bright. I think we will probably start seeing the CAR T cells used in the first or second line, and probably next year. But, until there's a cure, there will be room for new drugs and room for personalization of treatment. And so we obviously need to address the issue of cost, quality of life, accessibility. Can this therapy become cheaper and accessible to patients all over the world? And I think we need to work on that, and we hopefully can address that.
All right. Thank you very much, Dr. Abernor. And it's just encourage folks who may have questions for him to put those questions in the chat, and we'll address those during the panel discussion. But it really, having been a hematologist for many years and seeing the advances in myeloma be very slow, it's amazing in the last decade what new therapies are available, and CAR T certainly is an exciting one. Moving on, we're now going to hear from Dr. Mohammed Karfan Dabaja. He's a hematologist and oncologist, and in the blood and marrow transplant and cellular therapy programs at the Mayo Clinic in Jacksonville, Florida. He received his medical degree from the American University of Beirut, and today he's going to talk to us about a different CAR cell therapy, one for directed at lymphomas. Thank you.
Good day. First, please allow me to thank the scientific committee and the organizers for extending this kind invitation for me to be presenting today on CAR T cells for lymphoma. I have no relevant conflict of interest to disclose. The way I outlined my presentation is first, I am going to certainly focus this topic on lymphoma. I'm going to provide the background that led to the approval of what is currently commercially available for diffuse large B-cell lymphoma, starting with the Zuma 1 study, followed by the Juliet study, and then the Transcend study. I'm going to also touch on mantle cell lymphoma, sharing the results of the Zuma 2 study, which led to the approval of Rexucaptagen autoleucel for this particular indication, and then move into follicular lymphoma, first showing the results of the Zuma 5 study and the more recently approved product, tisagenlecleucel, which was just approved around a few weeks ago for patients with follicular lymphoma. And then I'm going to be discussing some of the second-line studies in patients with large B-cell lymphoma with a particular focus on Zuma 7 study. And then I'm going to be sharing some updates from ASH 2021, which have really looked into updated follow-ups on some of these products that have been approved, and also touching briefly on the ongoing research with allogeneic CAR T-cell therapies for lymphomas, just choosing some studies in the interest of time, and then finally closing with some take-home messages. So immunotherapy is everywhere. Immunotherapy is not just simply in scientific and medical journals, but it's also in the media. It's all of these advances are being noticed by the entire community worldwide. And certainly there is an interest and hope that these therapies will continue to improve the prognosis of these aggressive diseases, hopefully not only in lymphoma, but also in other tumors, including solid tumors in the future. So this slide here is meant to highlight the current state where all the commercially approved products are based on the use of patients' own cells or autologous lymphocytes. So these patients will undergo the process of leukapheresis, and then these cells are transferred to the manufacturing facility, where it may take sometimes between 3 and in some cases up to 5 weeks to get these products back into our hospital. Once these products are manufactured and the chimeric antigen receptor are built into the T cell, then these patients will undergo lymphodepleting therapy, and these CAR T cells will subsequently be infused and hopefully go and eliminate the lymphoma. So large B-cell lymphoma, if we were to go back and look into the efficacy of current standard therapy, first-line chemoimmunotherapy typically yields successful outcomes in approximately 60% or so of the cases. And we know that high-dose therapy and autologous transplantation can cure up to 50% of the cases, with the understanding that those patients must have chemosensitive relapsed disease. We know that outcomes of those patients is not as good if those patients have relapsed or refractory disease at the time of an autologous transplant, showing that perhaps less than 15% of those cases can be cured with an autologous transplantation. And we know from data like this one published in the Scholar 1 study, showing that the probability of attaining a complete remission in patients who have failed 2 or more lines of therapy, based on 2 North American databases, the MD Anderson Cancer Center and the Mayo Clinic with Iowa, showing around 7% CR rates, and in 2 European studies showing between 2 and 15% probability of attaining a CR rate. So certainly a lot of work to do. So Zuma 1 evaluated this CD19 targeting CAR T-cell therapy known as axicabtagene ciloleucel, and this was a study that was designed for patients who have failed 2 or more lines of therapy with large B-cell lymphoma, transform or de novo, and also patients who had primary mediastinal B-cell lymphomas. And what we can see here on this slide is that the complete remission rates for those patients who were of the large B-cell lymphoma type were around 49%. For the group that had primary mediastinal or the transformed follicular lymphomas was around 71% complete remission rate. For the combined population was around 54%. So approximately 7 to 10 time or fold increase in the incidence of complete remission compared to what had been there before CAR T-cell therapy, which was around 7% probability of attaining a complete remission. More importantly, these products can be effective regardless of the presence of adverse prognostic features. So as we know from the different prognostic tools, age typically is an adverse prognostic. And in this particular study, we could see that age 65 or older did not appear to confer an adverse prognosis, or meaning that the CAR T was able to overcome that adverse prognostic feature. The case was also similar for bulky disease, where those patients who had the tumors of more than 10 centimeters did behave as well or responded as well to the treatment as those who had less bulky disease. And that was also the case for cell of origin, whether the patient have the GCB or the activated B cell type, the responses were very comparable among them. So during the ASH meeting in 2021, the data was updated and it showed that at 5 years, the overall survival was 42.6%. So we seem to be starting to see that solid plateau line starting to emerge. So from year 3 to year 5, survival have almost remained very stable, showing that perhaps we may be seeing a glimpse of hope for hopefully a longer durable response and hopefully cure of these patients. This is the data for again, the 5-year update. And what is important to note here is that when we look at those patients who were in complete remission, the 5-year survival was around 64.4%. And the median survival time among the complete responders had not been reached. So this is certainly impressive data, considering the background comparison of the SCHOLAR-1, which shows only 7% CR rate, and extremely rare to see survivals at this 5-year update using or based on that SCHOLAR-1. So in terms of duration of response, we basically saw this signal several years ago, where those patients who actually attain an early complete remission, typically by 60 days and perhaps up to 90 days, are the ones who are destined to do the best, as seen in this green curve, compared to those patients who do not achieve a complete remission and rather only have a partial response, where the duration of response is not as durable and survival consequently is also compromised. The second product that was approved for large B-cell lymphoma is tisagenlecleucel, and this also was studied in a study known as the Juliet study in patients who have relapsed or refractory large B-cell lymphoma. Different from the prior study, this study did not include primary mediastinal B-cell lymphomas, and that is something to worth noting. And then what we could see here also in Juliet study is that survival was, again, very dependent on the availability or on the ability to attain a complete remission. So those patients who achieve a complete remission as either the best response or they achieve a CR by month 3 are the ones who are destined to do the best, with a 2-year survival of around 75.4%, whereas for all patients was around 40% or so. So certainly early attainment of a complete remission is a favorable prognostic factor in these cases. The third study, a little bit larger, and also important to note that with this particular product known as lisocabtagene maraleucel, this product actually, the CAR Ts are manufactured from both CD4 and CD8, and they are sorted out, manufactured separately, and then they are infused also separated with the with the CD8-derived CAR Ts being infused first, followed by the CD4-derived CAR T cells. Again, CD19 also far has been CD19 targeted products. Larger study size, around 269 patients. Important to note here that around a third of these cases have failed the prior autologous transplant. And when we see also survival outcomes, whether overall and progression-free survival, we can see also that those patients who achieved a complete response are the ones who have been destined to do the best, consistent with the previous two studies as well. In terms of progression-free survival, the complete responders, it hadn't been reached at the time this paper was published. And for the ones who had a partial response was 2.8 months, and for those who have stable or progressive disease, the median progression-free survival was around 1.1 month. So certainly emphasizing the point that attainment of a early remission is very important for long-term duration of these responses and also for survival implication. Mantle cell lymphoma, again, it's this study known as the Zuma 2 study was evaluating the efficacy of KTE-X19, also known as brexucabtagene autoleucel, in patients with relapsed or refractory mantle cell lymphoma. So again, using the very similar platform that has been used for probably most of these studies using lymphodepleting therapy with fludarabine and cyclophosphamide, the cell dose here was fixed at 2 million cells per kilo on a single infusion on day 0. And the primary endpoint of this study was an overall response rate, but by an independent review committee using the Lugano classification. 68 patients treated, so relatively small size, median age, I would say extremely reflective of the disease. All of these patients had either been refractory to, relapse after, or relapse during a BTK inhibitor, or a very small percentage of them, around 4%, were not able to receive a BTK inhibitor. Not surprisingly, the most commonly prescribed was ibrutinib, although there was a good number of patients who have also received acalabrutinib. Median of 3 prior line of therapy, and in some cases, up to 5 therapies were administered before CAR T-cell therapy. Looking at the overall response rate, which was a primary endpoint, again by this independent review committee, it was 93%, with around 67% of them being complete remissions. When we look at the median follow-up, here was a little over 1 year, so 12.3 months. Median time to initial response was 1 month, and the median time to CR was around 3 months, with a range of 0.9 to 9.3 months. Again, similar to what was seen with large B-cell lymphoma, we can see that overall response rate was consistent across all key groups. In this particular histology, we can see that Ki-67 proliferation index, whether less than 50 or more than 50%, did not appear to have an impact on, or limiting, was not limiting to the ability of this product to be effective, as well as the MIP scores here, in this case using the simplified MIP score, and also in terms of the different morphologies with blastoid behaving or responding, as well as those who have the more classical histologic variant. In terms of survival, the median progression-free and overall survivals were not reached after a median follow-up of 12.3 months. So certainly very encouraging data. At 1 year, the progression-free survival was around 61%, and the 1 year overall survival rate was around 83%. Again, this is data from ASH, where using data from a real-world experience, a U.S. Lymphoma CAR T consortium, retrospective analysis, obviously 14 centers. These are patients who underwent leukapheresis by June 15 of 2021, and the intent was to manufacture brexucabtagene autoleucel. 107 patients underwent leukapheresis, and 93 of them, representing 87%, were able to complete brexucabtagene autoleucel infusion. Median age 67. Most of the cases were male, which is consistent with the distribution, the gender distribution for this disease, and 45% had blastoid or pleomorphic variant. Looking at complete response, again, very encouraging, 64% at day 30 and around 63% at around 90 days or so. So let's go to the Zuma 5 study, and this is a study that led to the approval of axicabtagene ciloleucel in patients with relapsed or refractory indolent lymphoma, in this case follicular lymphoma. This was a multi-center single-arm phase 2 study. 151 patients were enrolled. Of them, 124 were actually of follicular lymphoma. The primary endpoint, again, was overall response rate using an independent review committee assessed by the Lugano criteria or classification. And the secondary endpoints were CR, investigator assessed, and overall response rate, duration of response, progression-free, and overall survival. In terms of the population, median age 60, so one may argue that perhaps some patient selection there. Median age of follicular lymphoma typically tend to be in the 67 to 68 years of age. Patients who were older than 65 were around a third of the cases, and patient with a 3 or higher FLIPI score was around 44% of these cases. Over half of the patients had a progression of the disease within 24 months from the first anti-CD20 monoclonal antibody-containing therapy. And around a fourth of these cases have failed the prior autologous transplant. Looking at the overall response rate for all patients was 92%. For the patient with follicular lymphoma was around 94%, with 80% of them having complete remission. Median time to first response was 1 month, and among the 25 patients with follicular lymphoma who initially had a PR, 13 of those 25 eventually converted into a CR after 2.2 months. So seems that with follicular lymphoma, we tend to see those later responses happening perhaps more often than what we see with the large B-cell lymphoma. At 1 year, the estimated survival was 93%, and the progression-free survival was around 74%. So very impressive numbers by all measures. This data was updated at the ASH meeting by Dr. Nilapo and colleagues, and the median survival had not yet been reached in the efficacy eligible patient with follicular or marginal zone lymphoma here. In follicular lymphoma, the higher response rate translated into a durability of response of around 38.6 months. And we can see here in the follicular lymphoma, median progression-free survival was around 39.6 months with a 2-year PFS of around 63.4%. For survival was around 81.2% at 2 years, again showing that these responses appear to continue to sustain over time. This is a slide showing progression-free survival rate at 2 years in key follicular lymphoma subgroups, showing that the efficacy was seen across all different prognostic factors, whether age, gender, and high tumor burden, or whether the patient had received or not a prior autologous transplantation. This second product, tisagenlecleucel, was approved a couple of weeks ago in the United States for treatment of adults with relapsed or refractory follicular lymphoma based on the study known as the ELARA trial. And number of patients was around 97 with a median of 4 prior lines of therapy with a high FLIPI score of 3 was more than half of the cases. And at the time of this publication, the median follow-up was short, around 9.9 months. The median survival had not been reached, and we can see here that per independent review committee, the complete remission rate was 62%, and the overall response rate was around 74% or so. So this data again was updated in the ASH meeting, and with now 17 months median follow-up, the overall response rate and complete remission rate were promising, as was summarized in this presentation. And interestingly, progression of disease at 24 months or by 24 months, and a high total metabolic tumor volume, which was defined as more than 510 cubic centimeters, appeared to play an adverse role here in terms of complete remission, having a high total metabolic tumor volume playing an adverse role here, as well as the progression of the disease. And that was also the case for progression-free survival. So certainly interesting data to keep in mind. In terms of allogeneic CAR T-cell therapy, I'm basically going to present this study known as the ALPHA study, looking at ALLO-501. And this is an allogeneic CAR T product, which basically represents also a CD19 genetically modified allo CAR T. The technology used here is the TALENT gene editing, and they also the purpose here is to disrupt the T-cell receptor and also using the CD52 gene manipulation to reduce the risk of graft versus host disease. So encouraging results here. First of all, I think that we go back to this slide. I think the potential advantages of an allogeneic product, or what we call off the shelf, is number one, is more readily available, and number two, perhaps we could have a more uniform product quality. In terms of lymphodepletion, the study encouraged lymphodepletion with fludarabine and cyclophosphamide. 98% of the enrolled patients were treated with the product in the single dose and in the consolidation cohort, respectively. So this is certainly much more predictable if we were to look back into all the prior studies, whether Zuma 1 or Juliet or the Transcend NHL 001. We can remember that at least 10% of those patients who were intended for the product to be infused on did not end up receiving the product. So here we can see that 98% of them do receive the product. The median time from enrollment to lymphodepletion was 5 days, certainly impressive. And the response rate, whether overall response rate and CR rates, were 75% and 50% respectively. Looking at large B-cell lymphoma, 61% overall response rate, and at follicular lymphoma, 82.6 response rate. Again, this is still a very short-term follow-up, and certainly more data will need to be seen to substantiate these findings. So let's move to CAR T-cell therapy to second line. 3 randomized studies have been published in the past few months. First was the Zuma 7 study, which compared axi-cel versus standard of care. Transform, which was presented as an oral presentation at ASH, comparing liso-cel versus standard of care, and Belinda, which was published in the New England Journal of Medicine, also comparing tisagenlecleucel versus standard of care. So 2 of these studies reported positive findings. In this particular case, axi-cel being superior to standard of care. In this particular case, liso-cel being superior to standard of care, but this third study failed to show an advantage of CAR T-cell therapy over standard of care. And I'm going to try to dissect those 3 studies. So the first study, Zuma 7, it was a phase 3 randomized trial comparing axicabtagene ciloleucel versus standard of care. The design of this study, basically randomization happening prior to as basically here, once patients were identified, they were randomized. 180 were randomized to receive axi-cel, 179 to receive standard of care. Those who responded in the standard of care continued with a transplant, autologous transplant, and those who did not respond were taken off the study. Primary endpoint was event-free survival. I'm going to be showing some of those definitions in a later slide. So important to note here is that of the 180 patients who were assigned to the CAR T arm with axi-cel, 170 of them ended up receiving the infusion, 94%, so 6% did not progress to receive the infusion, whereas for the standard of care, 179 which were assigned to that arm, only 64, representing 36%, who actually ended up receiving the infusion. In terms of primary, the endpoint of event-free survival, we can see that median event-free survival was 8.3 months for the axi-cel arm and only 2 months for the standard of care arm at the median follow-up of 24.9 months. In terms of efficacy, Axicell was better in all the variables that are shown in this slide, whether age, older or younger than 65, response to first-line therapy at randomization, or other prognostic markers, including double hit or triple hit lymphoma and others. So I want to really show this study here side by side to kind of dissect some of the differences. So the median age for this patient was very comparable among the three studies, Zuma 7, 58, Zuma Transform 58, and Belinda 59.5 years. For patients who were older than 65, representing a third of the case for Belinda and Zuma, for patients who were assigned to the CAR-T arm and received the intended treatment, 94 and 96 and 97% as shown here for the standard of care. Again, the number was between 32 to 46% based on each particular product here. But progressive disease at the time of the CAR-T cell therapy, only 1% here versus 26% here. Again, this study, the Belinda study, did allow for bridging therapies options, and the percentage of compared to, for instance, the standard platinum-based regimens mostly, compared to only glucocorticoid bridging option, which was limited in the Zuma 7 study. Also important to keep in mind is that the median time from leukapheresis to CAR-T, only 29 days for Zuma and Transform, but 54 days for Belinda. So these patients were getting so much bridging and salvage that there was a significant delay in the administration of the CAR-T. Crossover was not allowed in the Zuma 7, and there was some allowance on these two other studies. Primary endpoint, again, the three of them had event-free survival as primary endpoint, which starts from the time of randomization, and here the definition for each of the particular studies. In terms of responses, we can see here overall response rate for the CAR-T arm of 83%, for the Zuma 7, 86% for Transform, in this case lisocabtagene maraleucel, but only 46% for the CAR-T arm or the tisagenlecleucel leclusel for the Belinda study. When you look at the median event-free survival, 8.3 months for the Zuma 7 CAR-T, 10.1 for the Transform study, but only 3 months for the Belinda study. And certainly median overall survival in month was not reached in either of the studies. So I wanted to share this data, a very elegantly written letter to editor by Dr. Baumier and colleagues, where actually they reconstructed the event-free survival curve. Again, this is as perhaps close to scientific as one can imagine here, but certainly with the limitation that these are not randomized comparisons, but showing that in these two particular survival curves here, the Axicell versus Lysocell, there was no significant difference, or Axicell, whereas the Axicell versus the tisagenlecleucel leclusel, there was a significant difference. So these two curves representing Lysocell in red, the darker red being Axicell, and these were comparable outcomes, whereas the tisagenlecleucel leclusel had certainly a much inferior event-free survival here. And when we look at standard of care arms for the comparison, so standard of care Zuma and Transform were very comparable. And so the standard of care outcomes were not different among the three studies, whereas we can see certainly that in this particular analysis, the tisagenlecleucel leclusel certainly showing some inferior event-free survival in these reconstructed curves. So I'm going to be closing with this slide, and I think the take-home message is that CAR-Ts had definitely revolutionized the treatment of diffuse large B-cell lymphoma, mantle cell lymphoma, and follicular lymphoma, and I think they are here to stay. These products will probably continue to evolve, we may improve in the manufacturing time, we may perhaps improve on the toxicities, and that's a topic that will be presented later by my colleague, Dr. Yakub Aga. And certainly in relapsed refractory large B-cell lymphoma, now we are seeing survival in all comers of around 40% for patients in CR, 5-year survival of around 64.4%. We have one product now approved for second line, and responses appear to be remain sustained in mantle cell and follicular lymphoma. And as I showed in one of the studies, that allogeneic CAR Ts appear to be showing promise. I think the follow-up is still too short. The advantage, certainly no waiting time. Median time from enrollment to administration was 5 days. But I think the key question is, would it lower the cost of this product and make it more accessible for patients all over the world? With that, I would like to thank you for your attention and be happy to answer any question in the question and answer session. Thank you so much for your attention.
Thank you. That was an incredible summary of a lot of different trials in lymphoma, but really exciting, and to see this coming along and potentially providing not only better therapy, but less complicated therapies than some of the current therapies for relapsed patients. I think we'll, again, please put any questions within the chat, and we'll cover them during the panel discussion. But next, we'll move to our next speaker, who is Dr. Ibrahim Yaqub Aga. He serves as the head of the Hematopoietic Cell Therapy and Cellular Therapy Unit at Liv University. He did his PhD at that institution and was appointed professor of hematology, and currently holds the position of the coordinating professor of the Department of Hematology at that School of Medicine. He's going to talk to us today to discuss the management of CAR T side effects, an important thing for as we try to move this program forward. Thank you.
Very happy to share with you the management of CAR T cell side effect. First of all, I would like to thank the organizer for giving me the opportunity to be here. This is a remote presentation. I would love to be with you, but it's okay. So let's start. This is my conflict of interest slide. So for those who don't know me, I'm Professor Ibrahim Yaqub Aga at Lille University in France. So let's start. As you know, CAR T cell therapy, it's not just a treatment. It's not just an infusion, but it's a whole package. Everything starts when you identify your patient for CAR T cell, and then leukapheresis and bridging therapy, and then you get the patient in the hospital for lymphodepleting conditioning, and then infusion, etc. And then you need to monitor your patient for short-term, medium-term, and long-term complications. So I will focus on short-term complications because we don't have enough time to see all aspects of patient management. Let's start with the cytokine release syndrome, or CRS. CRS represents a systemic self-propagating inflammatory cascade that follows the infusion of CAR T cells. In some patients, of course. Actually, a similar phenomenon is also observed with some monoclonal antibodies, including bispecific T-cell engager antibodies, anti-thymocyte globulin, and T-cell replete haploidentical allogeneic transplantation. CRS is the second common complication of CAR T-cell therapy because the first one is the infection. Incidence varies from 30 to 100%. And about 10 to 30% of patients experience high-grade CRS. So when you infuse your CAR T, when your CAR T reach their target, they start secreting, I would say, a great amount of cytokines. These cytokines are secreted by the CAR T themselves, but by other cells of the immunity of the patient. This release of this amount of cytokine is responsible for hemodynamic instability and organ dysfunction. Usually, CRS occurs between 1 and 14 days, within 2 weeks after the infusion of CAR T cells, and can last from 1 to 10 days. But please keep in mind the first symptom of cytokine release syndrome is fever and your patient is neutropenic. So sepsis is the differential diagnosis, neutropenic patients. So you need to keep this in mind. You need to think about infection. Risk factor for CRS include underlying disease, of course, and tumor burden, and the dose and type of infused cortisol, and more importantly, its inflammation state before cortisol infusion. That's why we recommend you to delay the CAR T infusion in patients with active infection. How to manage? Actually, we need a trained multidisciplinary team, nurses, physicians, etc., a close collaboration with the ICU team. What about the prophylaxis of CRS? You need to closely monitor your patients for clinical symptoms. You need to grade CRS if it occurs, and to do repeatedly lab tests, inflammatory markers such as CRP, ferritinemia, fibrogenemia, and you need to treat your patient according to grade. So what to monitor? Actually, 3 things. It's easy, but it's very important. First of all, it's body temperature. So you don't have usually CRS without temperature more than or equal to 38 centigrade. And then you can observe some cardiovascular instability or hypoxemia. So you can grade your CRS within 4 grades, grade 1 just fever, and grade 2 fever with light disturbance for blood pressure, for instance, or hypoxemia, and so on, grade 3 and grade 4. So what about prophylaxis? Of course, some centers have tested early prophylactic tocilizumab, anti-IL-6 receptor, and corticosteroids in managing CRS. However, so far, there is no sufficient data to support a formal recommendation of these approaches. Maybe it will change in the future, but for now, we cannot give you a firm conclusion regarding prophylaxis. Now, how to manage your patients? If you are facing a grade 1, that's to say just elevation in body temperature, so your patient, keep in mind, is neutropenic, so you need to draw blood culture and other infection tests, and you start right away preemptive broad-spectrum antibiotics and symptomatic measures. Actually, treatment of CRS outside clinical trials. Otherwise, you need to follow the protocol recommendation. In the absence of improvement within 3 days, so you can consider giving your patient tocilizumab. For grade 2, we recommend to alert your local ICU team. And for emerging centers with less great experience, I would say, so we recommend to transfer the patient to ICU from grade 2 at the beginning, but with the learning curve, you will manage those patients at hematology or transplantation ward. Of course, you do the same blood culture, etc., and broad spectrum antibiotics, and you start tocilizumab IV 8 milligram per kilo. In the absence of improvement after 12 hours, so you can repeat tocilizumab. And then if your patient still with high fever, so you have to switch to dexamethasone. We don't think that more than 2 tocilizumab doses is useful in this case. So in case of deterioration, you don't need to do the second tocilizumab, you switch to dexamethasone at the dose of 10 milligram 4 times a day for 1 to 3 days. For grade 3, in this case, you need to transfer your patients to ICU. You start everything to cover infections, and you start tocilizumab at the hematology or transplantation ward, and then you transfer your patients, and then they start dexamethasone right away, and they can repeat 1 more tocilizumab, and in absence of improvement, they can add double the dose of tocilizumab. In case of deterioration, you double the dose of dexamethasone. Sorry, I said tocilizumab. No, it's dexamethasone. And for grade 4, So you do the same, you transfer your patient, you start with high dose of dexamethasone, and you can repeat tocilizumab, and in case of deterioration, so you switch to high dose methylprednisone IV 1000 milligram per day for 3 days, and then you taper according to the improvement of the patient. So this is the whole, I would say, algorithm how to manage the patient with CRS. Now, I would like to move on to rare complications. This is macrophage activation syndromes, which is very difficult to identify in patients with CAR T cells. Actually, severe CRS shares clinical features with macrophage activating syndromes. That's why I prefer the term of overlapping syndrome between CRS and MAS, other than distinguish CRS or MAS. If CRS does not respond to TOCI and high-dose corticosteroid, there should additionally be a high index of suspicion of underlying or concurrent MAS. When to think about MAS, in patients with persistent fever despite TOCI with one or some of the following: organomegaly, severe cytopenias, hyperferritinemia, more than 10,000. I would say from my experience, one of my patients had more than 120,000 nanogram per milliliter, etc. Liver dysfunction, coagulopathy, in particular hyperfibrogenemia. This feature is in favor of CRS mass overlap syndrome. In this case, patients should be monitored with twice daily blood tests: white blood cell, liver function, ferritin, CRP. And as you can see here, so you start dexamethasone at high dose, you give anakinra until IL-6, and you need to closely monitor your patient, because in absence of clinical improvement, you can switch to methylprednisolone at high dose, giving anakinra IV at high dose, and in case of persistent of deterioration, you can give the patient chemotherapy such as etoposide. But keep in mind, when you give etoposide, you can get rid of your CAR T cells. So you need to be aware of this, and you need really, this is a very severe, I would say, complication. To sum up, management of CRS combines symptomatic measures with immunomodulation using TOCI and corticosteroid. Corticosteroid should be subject to rapid taper once CRS is controlled. When 2 doses of TOCI fail to control CRS, dexamethasone should be administered. Clinicians should be vigilant of occult sepsis emerging post-TOCI, as fever and a raise in CRP may be absent because of tocilizumab. So be aware of occult sepsis. MAS is a rare but life-threatening complication, believe me. Now, what about immune effector cell-associated neurotoxicity syndrome, or ICANS? This is the second specific, I would say, complication after CAR T cell therapy. So it starts from alteration of consciousness, seizure, and end up by the coma. And as you can see here, you have 4 grades for this. So you need to evaluate to assess your patient with ICE score for patient aged more than 12 years old, and CEPD for children up to 12 years old. Here you have the same. You have the grading and how to manage your patient. Of course, the major treatment, it's corticosteroids in this case, as you can see here, and anti-seizure, etc. So depending of the clinical features, you need to monitor your patients with MRI, you need to monitor them with EEG, etc. As you can see here, we recommend to transfer the patient to ICU from the grade 2 and emerging centers, of course. Cytopenias. What about cytopenias? This is a real problem after CAR T cell therapy. Of course, you have cytopenia classical or expected, like any cytopenias after chemotherapy. As you can see here, lymphodepletion, and you have red blood cells or hemoglobin, platelet, and neutrophil drop down, and then you have the patient recover, and that's it. So this is the classical. You can observe this in the majority of patients treated with CAR T cells. But sometimes you have persistent cytopenias or prolonged cytopenias. As you can see here, you have lymphodepletion at the beginning, you have this drop on hemoglobin, platelet, and the neutrophil. Here the patient developed CRS, and then what we can observe, so hemoglobin recover, but the patient still having neutropenia, you know, and we give them GCSF and they increase neutrophil count, and then we need to give them many times, you know, GCSF. And if you look at the platelet, so the platelet almost 7 months after CAR T infusion, the patient is still thrombopenic. You have biphasic cytopenias, very specific to CAR T cells. So at the beginning, you have this nadir after chemotherapy lymphodepletion, the patient recover, and then you have a second drop and second cytopenias, what we call biphasic cytopenias. So what about prolonged cytopenias? It occurs after the period expected to be related to lymphodepleting chemotherapy and after resolution of CRS, biphasic pattern, 2 through levels with an intermediate recovery. If you do bone marrow aspiration, you can observe normal celerity without paucity of progenitor. Except patient with poor hematopoietic reserve or MDS, I will say a word on this later on. Rapid response to GCSF is suggestive of an alternative modality of bone marrow inhibition, distinct from chemotherapy-induced cytotoxicity. So if we look at the incidence, as you can see here, for neutrophil, it's 73% of patients present severe neutropenia. For thrombocytopenia, it's 55% with severe, 28% with severe neutropenia, and 55% of patients experience anemia. And for the duration, for severe neutropenia, median of 10 days. In total, it's about 20 days. And the same for platelet, 24 days when it's severe, and in total, 32 days. Prolonged cytopenias were observed with many type of CAR T cell, as you can see here, products. Okay, so the mechanism of late cytopenias, especially in patient in CR, because if your patient is not in CR, you know, there is a doubt about the mechanism of cytopenias. So first of all, pre-existing poor marrow reserve, because your patient had received a lot of chemotherapy before CAR T cells, of course, and especially with patients treated with prior allogenic hematopoietic cell transplantation and highly pretreated patients. If you look here, so the severity of neutrophil, for instance, it's very important in patients with less than 1 year after allogeneic transplantation. It's less pronounced in patients with no allogeneic transplantation before CAR T, and you have the same for platelet and for anemia. Now, pre-existing myelodysplastic syndromes, actually, it's very rare, but it does exist, believe me. 20 to 50% are cytopenic before lymphodepletion conditioning in real-world reports. That's to say, it can be toxicity of chemotherapy or pre-existing myelodysplastic syndrome. Several cases are suspected and reported to date. In my center, we observed 2 patients with this out of almost 200 patients who received CAR T cells. This is the cases. You need to think, you know, basically to drug side effects. such as cotrimoxazole or anti-pneumocystic prophylaxis. High-grade CRS can be responsible for prolonged cytopenias. As you can see here, there is a correlation between the grade of CRS and the severity of cytopenias. What the role stromal-derived factor 1 is playing in this? So this is the a study for delayed neutropenia following rituximab. Actually, B-cell progenitor and neutrophil are using SDF1. So this is the normal hematopoiesis, but this is late onset neutropenia because when you have recovery of B cells, so there is a consummation of SDF1 and neutrophil cannot circulate into the blood circulation. And as you can see here, there is a great relationship between SDF level and the number of absolute neutrophil count and others, of course. So how to manage of post-CAR T-cell cytopenias? You need to identify of potential patient with pre-existing MDS, identification of potential drug-related toxicity, treating the cause, close monitoring to the patient, and then you can use GCSF, EPO, TPO. In rare cases, allergic hematopoietic cell transplantation or autologous transplantation if you have a graft cryoreserved before CAR T cells. Now, let's move on to infection. There is an increased risk of infection in those patients because patient condition before CAR T cell, B-cell aplasia, neutropenia, severe CRS, and treatment characteristic, high CAR T cell dose, for instance. There are factors for increased risk of infection. As you can see here, you can see, sorry, this is in French. So you have acute phase, intermediate phase, and late phase, you know. So at the beginning, it's the bacteria, and then the virus all, all time, and the fungus, candidas at the acute phase, and then you have aspergillosis and pneumocystosis. So to this, so you need an anti-infective prophylaxis after CAR T cell therapy. So for neutropenia, you give GCSF. We don't recommend GCSF within the 14 first days after the infusion, but there's a controversy about this. Antibacterial prophylaxis, we don't recommend this. While our US colleagues recommend this, but we hospitalize the patient during this first phase, and the patient are followed as outpatient, you know, in the USA, in the nearby hotels. So it's not the same management for the patient. For antiviral, anti-pneumocystis, this is classical, but I would like to stress of systemic antifungal prophylaxis. We do not recommend systematically or routinely antifungal prophylaxis. However, when your patients receive corticosteroid, tocilizumab, etc., you need to think of this and you give something to cover, especially aspergillosis or other fungus. What about B-cell aplasia? So let me just give you just an overview regarding B-cell ontogeny. As you can see here, this is a start of bone marrow responsible for acute leukemia, lymph node, bone marrow and lymph node, and this is bone marrow again with plasmocyte. So if you look at the expression of CD19, so CD19 expressed in all these early stage of maturation. So when you give anti-CD19, so you can stop the maturation of B cells and stop the production of immunoglobulin, and this can be responsible for B aplasia. The same thing for BCMA. BCMA is present, is expressed on the late stage of maturation of B cells. The same thing. You can, I would say, trigger the absence of immunoglobulin or B-cell aplasia. So B-cell aplasia is an almost universal on-target of tumor toxicity and results in hypogammaglobulinemia. Occurs especially after antecedent CAR T cells in responders, especially patients with LL, is associated with xenopulmonary infection, notably with encapsulated bacteria. Children with B-cell aplasia should receive immunoglobulin replacement to maintain Ig level according to a institutional guideline for Ig substitution. For instance, as an example, 4 or 5 grams per deciliter. No, per liter, excuse me, there is a mistake here. There is no consensus regarding systematic supplementation in adults. To conclude, so post-CAR T cytopenias are frequent and can be delayed, rarely responsible for life-threatening complication in well-monitored patients. So you need to closely monitor your patient. Different mechanism, etiology to be elucidated, close monitoring of the patient, symptomatic treatment. In a few cases, allo or autologous transplantation is to be considered. So if you need to learn more about how to manage adults receiving CAR T cell therapy, so I recommend this European recommendation, this article on behalf of the EBMT, EHA, and JC. So you can see in this article everything in a practical manner, how to manage those patients from E to Z, from the selection of your patient till 15 years after CAR T cell infusion. So thank you very much. I would be happy to have your questions.
Thank you very much. That was, I think, an important addition to what we've heard about the exciting results with it, but remembering whenever we have patients and we're treating them, there is always something to also to be considered. We're going to open up the panel discussion, but first I'd like to introduce Dr. Mohamed Moti. He attended the University of Montpellier in France, where he completed his medical degree and also undertook PhD training at the University of Marseille in France. And he's now the professor of hematology and head of the hematology and cellular therapy department at Sorbonne University in Paris. So welcome, Dr. Moti, and have you maybe lead off the panel discussion.
Thank you very much, Ken. Really a pleasure to be with you here, and this is really a very exciting era for all of us. And I would like to thank you personally and your team for putting together such a lovely educational activity. And I think we had really a great talks. So while waiting for the question, maybe we can initiate the debate. And the debate is quite hot because obviously, in general, access to CAR T cells is very complicated these days. And when it comes to the Middle East, I think it's even more complicated than the rest of the world. But we've seen that now there are well-established indications both in lymphoma, in myeloma, but also in acute lymphoblastic leukemia, and more is yet to come. So maybe we can structure this discussion around different aspects. First, the indication and the results, and then we'll discuss about the management and the toxicities and safety issues and logistical aspects, and then that would cover, I would say, and then, of course, the perspectives. And I hope that all members of the panel will be able to contribute. So I think the most important indication today for CAR T cells is lymphoma. And let's start with lymphoma, the advanced relapse refractory patient. So maybe Mohamed, Rafat, and Ibrahim, in your different departments, and Ken, I don't know, in your hospital, what are the indicators? Who are the lymphoma patients that are relapse refractory referred to CAR T cells in terms of characteristics? Let's say age, comorbidities. Are there exclusion factors? Are there things that would tell you this is a good candidate, this is not a good candidate, beside, of course, the disease itself?
Maybe I would start. Thank you, Dr. Moti, for the question. And in our center, I would say that the recent results of Zuma 7, which have approved the axicabtagene ciloleucel for second-line therapy, those are cases that are not easy to identify. I mean, being a referral center, most of the time, by the time the community oncologist makes a referral, they already have started the patient on second-line therapy. So it's not, I would say, easily and feasible perhaps to see those patients unless they are patients that are internally referred by our own lymphoma doctors. So most of what we are offering CAR-T for are really patients who are relapsed refractory second line and beyond. I would say that our data here seems to be more consistent with the number that had been reported by maybe 25 or 30% of them have had already an autologous transplant and they are relapsing after that. So in terms of age, I just looked recently at this data. Our median age is somewhere around 61. So more real world than what has been described in the original studies. In terms of comorbidities, we get a little bit nervous when patients report history of seizures. I think that's really one of our main concerns, especially those seizures where the patient continued to have manifestations of them in the recent month or years. So in terms of cardiac pulmonary, we basically put the patients through the same vital organ testing that we do for autologous transplantation. So generally, we're expecting an ejection fraction of around 45% or so for left ventricle. And we expect DLCOs and FEV1s within decent, I would say 60% or higher appears to be our minimum. So we really put those patients through a very rigorous selection criteria before we can embark on the CAR-T product.
How old was the oldest one?
Oldest patient that we have performed here at Mayo Clinic is 75 years old.
Okay. This is the same story.
I have a question for Mohammed. So thank you for the clarification. So two things. First of all, why do you look at DLCO and so on? Because, you know, usually we consider just saturation oxygen, you know, more than 92 and, you know, without oxygen, it's enough for those patients because we don't have data regarding the impact of, you know, respiratory functions and toxicity of cortisol. So what we look at, it's the absence of hypoxemia.
So nice question, Brahim. I think that when you go back to the original studies, right, we with Zuma 1 and also with Transform, there was a good number of patients actually, if I remember correctly, over 25% of them or so would have required a trip to the intensive care unit. And we wanted to actually include this criteria more so for patients who have had an autologous transplant before. Those patients have come in, they have had an autologous transplant before, and we want to make sure that there is not any significant residual lung damage. So we have kept this criteria, and those patients who are below that threshold, we certainly will consult with the pulmonary team, and actually we will have them evaluate the patient and provide us some guidance. So I have personally allowed as low as 50%, but we certainly like to keep a close eye on the lung function that way. You are correct. I mean, pulse oximetry appears to be a good predictor. We were kind of still following the old criteria where almost a quarter of those patients were requiring an ICU trip and so on. So,
yeah.
So what about you, Rafat?
Yeah. So in terms of patient selection is about the same. I think the problem in America is that we have a variation in the healthcare system.
And our healthcare system cannot offer CAR T cells for a patient who's on Medicare, because Medicare does not, have a specific charge for these CAR T cells, and our healthcare system does not believe that they can cover the cost, associated with that. So we one of a few institutions in the country that cannot do that. Having said that, I mean, I think, it is easier than autologous transplant. I think we're now able to manage cytokine release syndrome and neurotoxicity reasonably well. And I'm impressed how well the patient do compared to an autologous transplant. I know it's scary when you say cytokine release syndrome and neurotoxicity, but boy, we know how to manage them today. And I think, patients are impressed because, as you know, in myeloma, I mean, they had an autologous transplant and now they relapse, and we put them through CAR T cells and they have a memory of both. And in a month, they go back to normal and they start, doing their normal thing. So it's, I think, hopefully, once we figure out how to make, the cost of that, CAR T cells much more affordable, I think it's an amazing therapy. It's very encouraging. I mean, I'm just impressed by the results we see in myeloma. We just need to make sure that it's accessible. How can we, I would say that one of the major first step is, can we find centers in the Middle East that can be specialized in producing these? Because I think, probably the cost will be less when you produce it locally than, send and ship the cell somewhere else to be done,
I think Dr. Bazarbashi, who will be there tomorrow, may comment on this, because I think their institution at the American University of Beirut is working on such academia, homemade, I would say, CAR T cells with the support from our Spanish colleagues, who actually managed very smartly to manufacture their own CAR T cells for ALL and recently for multiple myeloma, and that was presented actually at the presidential symposium at the last EHA, which was last week. Mm-hmm. Ken, do you agree with Rafat, I say, observations about the situation in the US? Because then Ibrahim will tell you in France, the system is very generous, offering it to everybody.
Yeah. Well, and I think to clarify for some who are not familiar what U.S. Medicare is, but that's basically the coverage folks have at age 65 and above. Is that what you were speaking to, Rafat?
Yes. Yes.
And that's been a real challenge, and even some other ones, it's been a challenge here. So access in the U.S. to these is limited also, and so obviously, and that's in a society where many other ones, in terms of trying to deal with these costs. I am encouraged through some of the symposium that we've had and discussions is how there is more and more research now going on of how do you decrease the cost of these manufacturing. And I don't know if some people wanted to comment. Rafat, I know you mentioned briefly an editing trial. There's work now to say, do we need to move away from viral vectors, which many of the CAR Ts utilize to do that, to generate these products, to seeing if we could do ones that don't require viruses, have editing, even nanoparticles are being looked at now to deliver CRISPR and things, which in theory, in terms of cost of manufacturing, may significantly decrease and also be able to facilitate getting things locally. I don't know what folks' thoughts are.
So we are involved in some of these trials, Ken. I think, when CAR therapy become, like any other drug, it should be really available off the shelf. I mean, I think the issue of collecting the patient-own T cells or, NK cells and then processing them, there's there's lag. I mean, you have somebody who's progressing, you cannot wait until these cells are manufactured and ready for that. So one of the trials we're involved in is, allo NK CAR that is basically, so that will be, an alternative, hopefully will be successful and it'll be easy. You just have, a bank full of these allo CAR T cells that have been edited to get rid of, ability to cause graft versus host disease and, be rejected by the T cells of the, recipient. I think, we're doing those trials. So hopefully in a couple of years, we'll have a product that is very successful, and that will make a huge difference.
No, I agree with you. And I think Dr. Karfan alluded to this talent technology, and we ourselves published a couple of years ago in The Lancet our experience in ALL. Unfortunately, my feeling is that we're not yet there. Obviously, we're testing them in the patient who are really failing everything. But I think you're right. At the end of the day, if the model has to survive, probably we need this so-called off-the-shelf, easily available process, unless we have these autologous CAR T cells being manufactured in 2 days. And we know there are big companies working on them. Yeah. But this is already a routine practice in China, I can tell you. And in China, they have all of these homemade, I would say, CAR T cells. And I went there to train on how to, manage CAR T cells a few years ago. And I was impressed. They would do the apheresis in Hangzhou. The car will drive 2.5 hours to Shanghai. 2 days later, the same car driver comes back with your CAR T cells. And I don't see that the efficacy is lower than what we are paying in our countries. Maybe Ibrahim, you'd like to comment on this.
Yes, I would like. I absolutely agree with you, Mohammed. So for the time being, we have this autologous CAR T, and we need more data for off the shelf. Why not? So for I would say low-income countries or the rest of the world. So I think the point of care can be the solution. But, first of all, you need the infrastructure, you need the clean rooms, you need the GMP facilities, etc., which is very expensive, up to $10 million, I would say. So you cannot open many centers, for instance, in the same country. So you need to centralize this. But there are some industrial working on this way. So nowadays, we order the CAR T, the product. So we send the cells and we get the product back. But they are working on other way. So when you need CAR T for your patients, you don't order the CAR T, but you order the kit, with reagent and viruses, etc. And you have the semi-automated machine, and you have the standardized procedures, and you can do it locally, point of care, I would say. Now the products are approved by FDA and EMA. But in the future, in the near future, the kit and the procedure will be approved, and your point of care will be approved because you need to work with the quality controls, etc. It's a bit complicated at the beginning, but when you start and when you finish spending all the money for the infrastructure, personnel, etc., then you can expect a lower cost for CAR T and faster, I would say, production. I'm totally agree with the 24 hours or 48 hours of, transduction, and you can, improve the system. But from the beginning, before starting, you need to think about all these things around the production.
Any other thoughts on this?
Yeah, there is work going on. Jen Adair, who's at the Fred Hutch in Seattle, is working to see about using the Prodigy, which is a sort of self-contained unit to be able to basically hook up your vector and your cells, and in a closed environment that doesn't require the sort of clean rooms that many of these things are done in. To be able to do this, again, it needs to be a special environment, but it helping again to try to bring down the cost of doing this. And that would apply not only to CAR T products, but other indications for ex vivo gene therapy. But yeah, I think it's an area of active research, but it's critical to really to get these products out.
Yeah, okay. Just like the comment on the Prodigy. Prodigy, it's not closed 100%. There is 2 steps. That's why we need this clean room for this. But for me, you know, if we try to have a parallel between allogeneic transplantation, haploidentical, and CAR T. So for haploidentical, you know, we've been working on haploidentical for decades, you know, with T cell depletion, etc., etc. It was something complicated, etc. It was very difficult. But once we got this post-Sci, we can do it everywhere. Now we can do haploidentical for many people. So what we need for CAR T, it's something the same sort. So something easy to do, you know, with good safety, etc. So we can democratize and disseminate CAR T for this.
Yeah, I totally agree. I think that the main key here is how do you provide a product that has undergone a quality control, that you know it's safe to prescribe to the patient. And I think that that's really the challenge. Yes, you can probably have institutions do it, but then is that going to be under a particular ongoing IND process where you have to have a single IND for every patient you infuse, or is that going to be? So I think the quality control, and I agree with Dr. Yaqub Aga, it's more complicated than it looks on the surface. I think the biggest disappointment, in my opinion, with the autologous has been the fact that we have had 3 products for the same indication for large B-cell lymphoma, and yet the prices were not reduced. So I mean, despite the fact that you have some sort of competition there,
but we've never seen prices in drugs decreasing. I've never heard of such story, you know, even if you have the same drug except for generics, of course, and biosimilars, but otherwise.
I mean, at least that was a wishful thinking, right? That the more products become available, the more likely you will see a drop. In fact, in the United States, the prices went up for those products and not really down when they got approved. So I think that unless we are able to offer these products to all mankind, we are still not doing a good enough job I mean, these products have to be able to be offered to all patients, whether it's in North America, in Africa, in Asia, and I think we have a long way to go still.
So regarding this, and you mentioned, you know, things across the globe and countries, and we are still in the access issue. Autologous stem cell transplant is a well-established treatment since 35 or almost 40 years. It is relatively safe, and actually it's quite affordable, maybe except in North America or in the US, but at least for us, it's quite affordable, I think. You can achieve this around 20,000 euro in France. It's going to be like $5,000 or $6,000 in India, and I guess. But then, Mohammed, you showed us some, you know, 3 trials, randomized trials. So we are evidence-based guys, and 2 of them are showing the superiority of CAR T cells. The third one is not showing this. Still, actually, everybody concluded from the 3 trials that auto transplant is dead already in first relapse. Is there a consensus on this, or is there still room for autos somewhere? I can see Rafat smiling, Mohammed is thinking, Ibrahim is smiling. So it looks like the environment is different from one place to another.
So let me say that I think the confusing part on the study designs is that the standard of care is not meant to be the autologous transplant. The standard of care is the platinum-based second-line therapy. So, and you can see that it was really consistent with all the previous studies that almost 2/3 of the patients who received second-line therapy for that particular group of cases who were primary refractory to an anthracycline-based regimen or relapse within 1 year from the last dose, the patients who were able to demonstrate a response and move forward was only 1/3 of those cases who ended up getting the autologous transplant. So autologous transplant has been known since the day of the Parma study that has limited efficacy in the persistent disease setting or those patients who do not have an objective response rate. So again, there is, to my knowledge, a retrospective analysis comparing auto transplants to CAR T therapy. And this was undercarried by CIBMTR. And in fact, when you look at that study, and these are patients that were in partial response, you can see that actually auto transplant did very well in that particular group. So a lower relapse was 40% versus 53%, and also had a survival of 69% for the auto transplant versus 47%. Now, all the caveats you can imagine, right? Retrospective study, reporting the data you have, and so on, difference in time. But it shows you that when you have that particular comparison, that auto transplant is not dead yet, in my opinion. And here we have to be very careful with interpreting those studies, that they were not intended, it was mostly a standard of care where they have to really show a response to platinum before they can go to the transplant.
Same feeling by you, Rafat, Ibrahim, Ken?
Yeah, absolutely. I think I would like just a comment about you, evidence-based guy. Actually, randomized studies doesn't mean evidence-based for 100%. There is
of course.
recently a paper in Science showing that only 35% of randomized study were reproducible. So there is a lot of things, and there is the experience. So I would say, with the experience, we really got a breakthrough with CAR T for those patients, because we know I would say, the prognosis of our patient we are taking care of, etc. And we saw the effect of CAR T, how to really change the prognosis and the conditions of the patients. So for me, CAR T are really effective for a patient with lymphoma. Now, not everybody is candidate for autologous transplantation. This is the problem, and I would say it's very difficult, but for CAR T, we can target a larger amount of patients, especially those with refractory or relapsing disease.
Excellent.
I think Professor Muhti's questions was really to say that, I don't think we can close the door on autologous transplant. I think it's an effective treatment. We should keep it around. It's good for patients who are lymphoma patient chemosensitive. It's good for myeloma patients. We should not say it's a done deal. I think it's still very effective and cost effective.
And it has become relatively cheap compared to the others.
But I think maybe to follow up a little about it, the way I sort of review CAR Ts is we have proof of principle of this as being, having a potential to affect, but we're not done with it in a sense. I think there are, why are folks relapsing? And do they need more than one antigen? So there's work going on to look at whether you need to try to, impact CARs that are either identify themselves 2 different antigens or to even use 2 different CARs. There's discussions about that. I think there's some more recent data that some of the side effects that they're seeing with CAR T may be related to the construction of the CAR. And there may be redesign issues that might also improve the safety profile. So I hope that the folks that are listening realize this is still early days for this. It's incredibly exciting, but we still have more work to do.
Well, this is actually a wonderful conclusion for our session today, guys. This is fantastic. I think it has been really very enjoyable, and I think the key message is that this is a revolution, but this is the beginning of the story. And that reminds me, of when you look to the history of allotransplant, autotransplant, and things keep on moving. It's like everybody remembers Windows DOS, and now we have Windows 12 and 13. So we're waiting now for the CAR 12, 13, etc. So this is really fantastic. I would kindly remind our attendees that we will come back tomorrow with another session entitled State of Cell Therapy Development in the Field. And I'm sure you will learn a lot. But I think in the meantime, on behalf of Dr. Cornetta, the organizing team, the wonderful faculty, I would like to say goodbye. And wherever you are, please stay safe and keep well, and see you maybe tomorrow. Take care.
Thank you, everybody.
Thank you very much.
Take care, everyone.
Thank you very much. Okay.